Can you see my screen?
Yes, sir, we can see your screen.
Yeah, okay. Thank you very much, Dr. Sheila and the organizers for inviting me for this opportunity. Now, in the 720 seconds is too little a time. So I'm going to confine myself to some aspects which are not generally discussed. I was very happy when the president of the IMA mentioned about the possibility of dehumanization, depersonalization. I think this is very, very important. I belong to the BC era, not before COVID, but before computers. I was the last neurosurgeon in India who was trained even before the CT scan came. And over the next couple of minutes, I'll try to show you that even if you're a retinal specialist and an absolute pundit, so far as diagnosing pathology in the retina is concerned, the patient is concerned, you need to get across to the patient virtually. This is the most important thing. So tender loving care can be exhibited virtually, and I'm going to show you how. We are all aware that telemedicine essentially consists of the application of hardware, software, connectivity, acquiring images, storing them, retrieving them, digitally manipulating them, and so on. The most important thing is we need to be future ready. When I started telemedicine 21 years ago, nobody taught me. But today, the world is changing so much that I think it's absolutely essential that all of us undergo a formal orientation and training program. Now, I would like to emphasize again and again that this clinical wisdom should be contextual. What is to be done at that time, at that place, for that patient by you, from where you are, taking the socio-economic picture and specific requirements of the patient and the family. I never treat an MRI image. I never give an opinion on a CT image through teleconsultation. And I implore all of you not to restrict your treatment to the diagnosis of the retinal image, but get across to the patient. That is most important. Always try to find out why the patient did not come to you physically. There must be some reason, and that would definitely be helpful. Again, never ever get overawed by rules and regulations. There have been several judgments which have said that clinical judgment is the most important thing. Technology is only a means to achieve an end and not an end by itself. As a clinician, do your best, act in good faith, having only the patient's interest first and foremost. In the early years of my teleconsultation, when technology was a problem, there have been several occasions when I called off the teleconsultation. There is no ego involved here. I said, look, I am not happy with the quality of the images. I'm not sure, I may miss something. So better you come over personally with the images. Now, these things are unlikely to happen now, but if it does, please do it. Just to give you an example, I'm an old-fashioned doctor, and perhaps I would like to do a rectal examination to find out the size of the prostate. My student is more comfortable with the 4D pelvic ultrasound. So for him, teleconsultation is fine. For me, it is not fine. So this is what I mean. The context, and the context alone is the single most important thing. The same standard as used in a face-to-face examination. Last Lexel, the inventor of the gamma knife said a half a century ago, a fool with a tool is still a fool. And I think that is very important. Professional judgment alone matters. Now, those of us who intend to use telemedicine as a major component, we need to understand and streamline the entire workflow, starting with appointment scheduling, management of the staff, reduce patient wait time. Just as you do in a face-to-face encounter, patient wait time also should be reduced in a virtual encounter. The workspace design must be convenient and should enhance the interaction. Most doctors giving teleconsultation are not aware that body language is very critical. The way you dress, treat the patient with importance. I mean, personally, there may be nothing wrong if you are wearing a pajama or a banyan and giving an opinion. The opinion is the same, but still it is necessary that some amount of formality may be there. The patient experience is critical. He must go back with the impression, wow, that was a fantastic consultation. It was even better than a face-to-face consultation. So this is what is required. How many of us are aware or pay any importance to the room in which the teleconsultation is given? There are a lot of things here. The distance from the floor, the distance from the wall, the dress you wear, the lighting of the room. Daylight is not enough. Even if it is at 12 o'clock in the afternoon, you must have artificial natural light. 2,800. There are a lot of technical details here. There is no time to go through all this. But please be conscious and take a teleconsultation exactly as you would do. After all of us spend a lot of effort, time, and money in building our consulting room. This should be the same thing so far as a teleconsultation is given. The color of the wall, the type, whether it is shiny, glossy, backdrop, everyone is important. I'll quickly go through a few clinical images just to tell you that whether it is the retina or whatever part of the body it is, the clinical continues to be the most important. We have done about 35,000 teleconsultations in dermatology over the last 2 decades, and I'm not aware of a single instance where a mistake was made. On several occasions, our dermatologist, of course, had to call the patient because he wanted a biopsy, but whatever it is, a correct differential diagnosis has been made, provided the history is there. The history is very, very important. Now, just to show the importance of telemedicine, we run telemedicine centers at 14,500 feet height in the Himalayas. Our dermatologist diagnosed tinea capitis in a single child who was brought to the telemedicine room. But being an experienced person, he said this usually comes in monasteries. So he persuaded, he asked us, and we told our staff. We went, we were proactive. We went to the monasteries, and just as we predicted, as the dermatologist predicted, we picked up about 25 children in the monasteries, all of whom had tinea capitis. Just an example of somebody whom we initiated thrombolysis from Apollo Main Hospital, Chennai, 2,800 miles away, external temperature minus 25 degrees centigrade, December, Saturday evening, chest pain. My emergency doctor said, even though the ECG is normal, I don't like the look of this guy. It just doesn't look all right. And he told our nurse that don't send him back. Repeat the ECG after 45 minutes. And as clinically predicted, we were able to demonstrate an ST elevation, and we initiated thrombolysis from Madras to a patient in the Himalayas. Yet another example of supraventricular tachycardia. This was even more dramatic. 220 was the pulse rate, and it so happened that the person trained in the use of a defibrillator was on leave that day. We had a young local girl who was only talking Himachalese, as they call it, not even Hindi. But our doctors in the emergency ward, a very well-equipped emergency ward in Chennai, using a mannequin, he demonstrated to this young 20-year-old girl what is a defibrillator, showed her how to put the paddles, what is it, and through an ordinary webcam, handheld her, telementored her, and made her do the very first defibrillation in her life. The patient became absolutely normal and was discharged. I think in 2021, it's a crime to make children like this come back for a follow-up. Pediatric cardiac surgery obviously can be done only in tertiary and quaternary care institutions, but follow-up can be done through telemedicine. Again, another example, acute abdomen. All that it is required was a doctor to say is a bladder is distended, a catheter was put, and lo and behold, the acute abdomen totally disappeared. Tele-emergencies, a very bad wound, again in the Himalayas, we were able to tell the local MBBS doctor there who had never sutured a complex wound like this, what is to be done. And a few days later, you can see the patient doing much better. Personally, I have given more than 3,000 teleconsultations in the last 2 decades. 2 minutes it takes me to do a detailed examination, except the fundus examination, of course. I'm able to do a cranial nerve examination, ask the patient to look to the left, to look to the right, and so on. This is a patient in Africa, a bead of pus outside in the scalp tells me that there's a possibility of osteomyelitis, intracerebral abscess, etc. And I advise the bone flap to be removed. A detailed neurological examination through an ordinary mobile phone. This is a patient, and this is all that I want before I can actually give a prescription. Obviously, this little boy has got mental retardation. All I had to do was to spend 10 minutes with the mother and tell the mother there is no point in bringing the child to a tertiary care hospital. The detailed evaluation of a radial nerve injury, I'm able to examine the individual muscles, do a detailed sensory examination, and so on. A meningomyelocele diagnosed within 45 minutes of the child being born at Andaman and Nicobar Islands. It takes me, an experienced neurosurgeon, a minute to make a confident diagnosis of future management of this patient. Now, here again is an example of a person who the family, I was very surprised when the family said, I refuse to advise the patient without seeing the patient. And then the patient said, sir, with a mobile phone, I will show you the family. Is this okay? So yet another instance, this was a patient from Dubai, and I refused to make a prescribed anticonvulsants, though the history very strongly suggested a temporal lobe seizure. I insisted that they capture it on a video, on a mobile phone, and they sent me this video. Unfortunately, the video is not playing here right now. And similarly, another patient a few months ago during the pandemic, again in the Himachal Pradesh, examined at home. I could go on and on like this. This is just a demonstration of how, when you give a teleconsultation, it is essential that your qualifications, your registration number, you can see Tamil Nadu Medical Council registration number, permission obtained from so-and-so to record video, and you can see on my letterhead the prescription. I put the generic name, carbamazepine, 100 milligrams at 8 a.m., 200 milligrams at 8 p.m., and so on. Fundus not examined, telephonic review, etc. All this sent by email. So you could go on and on, but then I need to confine myself to the time. So I would like to conclude that it is not technology which is important. In 2021, technology is becoming available. What, in my opinion, is required if telemedicine is to really take off, it is not enough if there are a few thousand doctors. 20 years ago, there were a handful of doctors. Today, perhaps there are a few thousand doctors passionate about telemedicine, but that is not enough. The patient should demand a virtual consultation. And when will he do this? He will do this only when he gets a tremendous experience. When those treating you don't introduce themselves or make eye contact or say what they are doing and why. When these simple things are addressed, it makes all the difference. So once again, my take-home message would be, it is not the technology, it is not the process, it is you and you alone who can produce a customer delight by the way in which you interact in those few minutes. How many of us today, with all the technology available at our resources, listen to a patient? Sir William Osler, 150 years ago, said, listen, listen, listen. He is telling you the diagnosis. And this is what I think is the single most important thing. Not technology, not EMR, not hospital information system, not complying with the telemedicine practice guidelines, but sympathize, empathize, give tender loving care virtually, wipe the tear off the patient. For the patient, what you are telling him are pearls of wisdom. And please remember to communicate this. This can be done virtually. Thank you, the organizers, once again, for giving me this opportunity.
Thank you, sir. Wonderful talk. Before Rajiv, I'm just interrupting for 30 seconds. The idea is, I think Dr. Abdul Kalam gifted a book called Man and Medicine it's a compassion medicine by the first Dalai Lama Rinpoche and also Dr. Schlim. I think it mentions about how a doctor has to be compassionate. And I'm writing a book, Compassionate Eye Care. I think you summed it up by saying, we need technology, sir, but at the same time, everybody should use compassionate eye care. You need electronic media, everything, because we are going to treat lakhs of patients through this and not hundreds of patients. So I think with this, I give it to Rajiv.